Colleagues, we want to get started with Health and Human Services. Today we have 4 agency report outs, and we'll get started with the Maryland Health Benefit Exchange with Victoria Martinez.
Thank you, Mr. Chair and members of the committee. My name is Victoria Martinez, and I'll be covering the Maryland Health Benefit Exchange budget analysis today. The Maryland Health Benefit Exchange provides a marketplace for individuals and small businesses to access affordable or no-cost health coverage. As you can see on the first page of the analysis, the fiscal 2027 allowance increases by $140.7 million, or 17%, for a total of $957 million. Moving on to an overview of the fiscal 2027 budget, Exhibit 1 on page 4 provides an overview of the agency's spending. Most of the agency's budget, 87%, goes towards reinsurance and state subsidy payments, and the remainder of the budget includes 7% for information technology and 6% for administration expenses. And Exhibit 2 on page 5 shows the breakdown of these expenses. Exhibit 3 on page 6 shows what is driving the $140.6 million increase. The largest changes are a $79 million increase for payments within the reinsurance program and $40 million for the state subsidy program. There are also various increases to implement changes to Medicaid eligibility and enrollment that are required by the One Big Beautiful Bill Act. This includes various increases for personnel, IT systems, call center, fulfillment notices, and marketing and outreach costs. In terms of personnel that's discussed on page 8, there are 12 new regular positions in the fiscal 2027 allowance, and all of these positions are to support the implementation of requirements from OBA. MHBE had a small vacancy rate, about 2%. Moving on to the key observations, the first key observation, beginning on page 9, is on federal changes impacting the marketplace. In addition to changes to Medicaid eligibility requirements, OBA and the CMS Marketplace Integrity Final Rule created significant changes in the marketplace. Significant changes include prohibiting financial assistance for households entering in the special enrollment period, pre-enrollment verification requirements that ends auto renewals, the end of eligibility for financial assistance for many lawfully present immigrants, and the end of eligibility for enrollment in a health plan through the marketplace for DACA recipients. The second key observation, beginning on page 10, is on the implementation of the state subsidy program due to the expiration of enhanced premium tax credits. A premium tax credit assists eligible individuals with the cost of premiums for health insurance, and individuals are eligible with annual household incomes between 100% and 400% of the federal poverty level. The American Rescue Plan Act of 2021 enhanced these premium tax credits by removing the 400% FPL cap on eligibility, and the Inflation Reduction Act of 2022 extended the enhanced tax credits until they expired at the end of calendar 2025. In addition to expanding eligibility, the enhancements of the premium tax credits also made premiums more generous by lowering individuals' required contributions to the cost of premiums. Exhibit 4 on page 11 shows the expected contributions for premiums, showing that individuals had the lowest contributions under the enhanced premium tax credits, and the highest contributions would have been at the end of the enhanced premium tax credits. However, the state implemented a state-based subsidy program at the beginning of calendar 2026 to mitigate some of the increases in expected contributions, making premiums more affordable. The state subsidy program incorporated the Young Adult Subsidy Program, and Exhibit 5 on page 13 shows the enrollees in a qualified health plan by age. From 2025 to 2026, there was an increase in the population served by the Young Adult Subsidy, but there were decreases in enrollment in older populations. The end of the enhanced premium tax credits in part contributed to a significant increase in the individual market rates in calendar 2026 and the cost of premiums. Exhibit 6 on page 14 shows sample monthly premiums, and Exhibit 7 on the next page shows the average year-to-year premium change, showing an increase in the cost of premiums of about 13% in 2026. The increased cost of premiums could have also led individuals to choose more affordable plans with higher deductibles. Exhibit 8 on page 16 shows enrollment by metal plan, showing an increase in plans that are more affordable but offer lower levels of coverage. Exhibit 9 on page 18 shows that the implementation of the state-based subsidy program has mitigated some of the anticipated premium increases and enrollment losses. In terms of the program's cost, a budget amendment added $52.3 million to cover subsidies for the second half of fiscal 2026, and this is in addition to the $26 million for the young adult subsidy program that was incorporated into the program. The funding source for the program is the same source as the reinsurance program, which is supported by a 1% state provider fee assessment. And Exhibit 10 on page 19 shows the closing fund balance, showing that the balance is anticipated to decrease significantly in 2026, with both the reinsurance and state subsidy programs drawing from the fund. The third key observation on page 19 discusses the reinsurance program and forecasted funding. The reinsurance program was established in 2018 to address rising health insurance premiums, and MHBE receives federal pass-through funding to support the program. Exhibit 11 on page 20 shows the actual and estimated reinsurance costs and federal pass-through. Total costs in calendar 2024 were $71 million more than in 2023, and they were also 6.8% higher than anticipated. And the last key observation, beginning on page 21, discusses enrollment in a qualified health plan through the Maryland Health Connection. Exhibit 12 on page 22 shows that there was about a 15% increase from 2024 to 2025. And lastly, page 23 discusses our recommendation. DLS recommends adding language requesting a report on the reinsurance and state subsidy program costs and forecasts. And that concludes my presentation. I'm happy to take any questions.
Well, thank you very much for that great analysis. I'm not Senator McCray, but I play him sometimes in committee. Any questions for the analyst? Thank you very much. Welcome. Good to see you.
Thank you so much, and appreciate having the opportunity to be here. For the record, Michelle Eberly, Executive Director for the Maryland Health Benefit Exchange, and with me today, I have our Deputy Director, Johanna Fabian Marks, and our Chief Financial Officer, Tony Armiger. And first, I'd just like to take a moment to thank Victoria for another year of just very diligent work and really asking all the right questions and looking into how we've been operating and taking a lot of difficult information and making it easy for all of us to read and understand. So we appreciate your work very much. Each year, our team works very diligently to be efficient with our funds and to, at the same time, keep our consumers at the center of what we do and make sure the work we're doing is helping Marylanders get coverage through Maryland Health Connection. This past year, we had another really successful year despite the challenges that were before us from the expanded tax credits that did not get continued and the other federal obstacles that were put in our way. We've given you in the testimony a highlight or a link to our 2025 annual report, so you'll see all the highlights from last year. And I do want to just mention a few accomplishments that we've had and how it has really helped our operations. So we have our AI, we're using a lot of AI, we're using it in a very controlled manner, but we launched an AI enrollment status this year, which has allowed consumers to get really immediate updates on their cases. What we have found is that within the first 2 weeks of rolling out that pilot program, the AI-assisted case status handled 8,600 enrollment-related calls. typically we'd be paying about $10 a call for a consumer assistance worker or a call center worker to help. So we're estimating that we will start to see some real significant savings in funds by this AI-generated program. And the other AI-generated that we implemented was our virtual assistant, Flora, that addressed 1.7 million queries in 2025. And again, that's taking all of the information that we have in our closed system and providing real robust answers to questions, which have really helped out a lot. And then the other one I want to highlight is just that we launched our comprehensive small business web portal this year that streamlines health insurance enrollment and benefit management for small business employers, employees, and brokers across Maryland. So finally, our small businesses can truly offer individual choice to their enrollees to pick whatever health plan they want, and they can do that through Maryland Health Connection, and we'll take care of all that effort for them. Also in the presentation you received today is a link to the presentation our CIO made to our Board of Trustees at the February board meeting, which outlines our 2026 roadmap. You'll see that there's a lot of work that will be being done for OBA, the work we are doing on behalf of OBA. So that is going to take significant amount of work. We thank you for recognizing the work we've done in the past and for making sure that we have gotten sufficient pins for the work that we've been doing in the past. And the budget, as you see, does recognize the successes we've had. And I want to point out one in terms of our young adult subsidy enrollment. With your help, we have been able to have that premium assistance program in place, particularly focused on young adults. We saw tremendous growth in that age 18 to 37 age group. And in fact, it's more than 30% of our entire risk pool. So as you know, if you look at risk pools and how we want those younger, healthier people in there, it's doing exactly what we want it to do. The downside is that we've had more people enroll in that program than we'd anticipated. So we're going to continue to watch that premium assistance program we put in place for 2026, and we'll monitor that and see what impact that will have on the reinsurance program. And I'm going to, I think, stop there. I'm going to hand it over to Johanna to talk about the two questions, respond to the two questions specifically about the reinsurance program. And there's a little more in the testimony, but I won't regurgitate it here. But thank you again for supporting the efforts we do for Marylanders.
So the first question we received asked us to discuss how estimated costs for the state premium assistance program were determined given that parameters haven't yet been established for plan year 27. We typically talk about plan years. They're equivalent to calendar years. So our Board of Trustees sets the premium assistance parameters typically the summer before the coming calendar year. So in the summer of 2025, they set the program parameters for 2026. This summer, they'll set the program parameters for 27. However, when developing our FY27 estimates, we had to make an assumption about what the program parameters might be for calendar year 2027. To do that, we relied on modeling we performed last summer to help illustrate to the board what costs for the program might look like in out years. Those are just projections, assuming parameters that the board might choose, but those actual parameters will be set this summer. However, in the interest of coming up with that estimate, we went with what felt like something that might be a likely choice. But as we get more data this year on the enrollment and costs of the program and our reinsurance pass-through funding from the federal government, we will be updating all of that modeling and presenting revised recommendations to the board. The second question directed us to discuss how we will ensure that the reinsurance program has sufficient funding to meet obligations while implementing the state subsidy program. And this is something that's very much on my and all of our minds at the exchange because, as Victoria mentioned, the reinsurance fund supports both the reinsurance program and the state premium assistance program. We are very mindful of how that funding is coming out and ensuring that we do meet our commitment to the federal government to fund reinsurance through the end of the current waiver period, which is the end of calendar year 28. The board does have tools to control premium assistance costs if necessary by updating the eligibility parameters, as I mentioned, for calendar year 27. The board also has the option to take action to reduce costs this calendar year by reducing subsidy amounts for those who newly enroll later in the year. So as we continue to monitor the program, we'll be conferring with the board on how they may want to take those options into consideration to ensure that we maintain the solvency of the fund and of the reinsurance program.
Senator Augustine.
Thank you for the presentation, and just for my, for my understanding, the possession of that money that's coming through for the reinsurance.
Do you want to speak to the mechanics?
Yeah, yes, we do. I mean, actually, in the beginning, MIA, since they collected, they audited, they kept it for a few years, but now we have possession of the funds. And basically, once a year, after MIA collects the funds from the carriers and audits them, they will do a transfer to us probably around October. Last year, it was around October, and it's probably around about $140 million, 130 to $140 million will get transferred to us.
Okay, and then once you, what do you all do with it? Once you receive it, is someone managing that, or are you all internally, or is it how are you all handling that money?
Basically, it's we don't get interest on the funds, and they're just the funds aren't really sitting there. They're just in like that's not the bank or anything like that. The actual funds are with the state, but we just manage the funds and we pay out what we pay to the carriers. For instance, the carriers, we pay out maybe $700 million, of which the federal government might pay $600 million. So the other $100 million comes out of the MHBE fund. Mm-hmm. In addition to that, the young adult subsidies, and now it's the ARPA subsidies included to that. We reimburse MHBE for those funds. Okay. So every year we have funds coming out of, going into the fund once a year from MIA, right. And then we take the funds out to reimburse MIA, reimburse us for paying the carriers.
Okay, but we are not, that money is not put to work when you all are in possession of it.
So if I might, the money comes in, is sent from the MIA, or the MIA collects it. Yep. Treasury holds it. Right. And then we get it from Treasury. It comes into us,
so
but we get it.
Treasury's managing it.
Yes.
Okay, that's what I was trying to figure out.
Yes.
Okay, so Treasury are the ones who are actually managing
that is
the
correct.
funds.
That is correct.
That's really what I was asking.
Okay.
Okay, so it's Treasury, and that I do get and I understand. Then there's like, can you, just for my understanding, the contractual services, which is a significant line. What is contractual services?
So this is something very unique that the exchange does. Many other agencies will do firm fixed contracts with big, large IT firms like Deloitte, Conduit, Optum. We, many years ago, took a different approach, which we call IDIQ, indefinite delivery, indefinite quantity. Mm-hmm. And it's a lot more labor on our team to do. So we put out master vendor contracts. We get the master vendors approved. And then within there, we have different labor categories, and we do some our requests for resumes through those master vendors. Then those folks, and we have about 140 of them, They actually are on site. It's almost a co-employment relationship because we manage their work. We determine what they're going to work on. We make sure that we have the latest technology, people that to do the latest technology, like we will have a mobile applications team, we'll have a Salesforce team, and it allows us to be very nimble and also really manage our spend. So you'll see that our IT spend is really small in comparison to if we just did these large contracts out. And we can manage that work and be very nimble in how we operate. And that's what those are, that's what falls under there.
Okay, that's very helpful. And then just a very last question on that. Is that subject to state procurement?
Oh, yes. Well, yes and no. Because we are an independent unit of
Right.
state government, our Board of Trustees
Right.
approves our procurements.
Right.
The Board of Trustees has a procurement policy, and it mirrors the
State?
state
It
procurement.
does mirror it?
So it's, oh yeah, it's all, and it's on our website, and it's very defined, and the
Okay.
board has to approve it. And, I mean, so, for instance, I can't approve anything over $200,000. It has to go to the board.
Okay.
We have different, all the categories in there, all
Okay.
the different procurement types, et cetera.
Thank you, thank you, thank you very much.
Well, Madam Director, I'd just like to say a couple nice things about you. You know, service is one of the greatest honors. And as you transition, we can't say thank you enough for what you've done for the state of Maryland, leading the helm 8+ years with the agency for over a decade, and just say thank you, thank you, thank you for your leadership and how much you poured into the state of Maryland.
Thank you. It's been my pleasure and honor.
And Ms. Martinez, as we have our last day of just budget hearings, just want to lean in and say thank you for your leadership as you helped us navigate these waters and being able to understand multiple agencies. Colleagues, if we can, I see my colleague over there, bring up the Maryland Department of Health Regulatory Commissions and ask for Ms. Ann Braun.
Thank you, Mr. Chairman, members of the committee. Today I'm presenting the budget analysis for the Health Regulatory Commissions. This includes 3 independent offices within MDH, the Maryland Healthcare Commission, the Health Services Cost Review Commission, and the Community Health Resources Commission. It also includes the Prescription Drug Affordability Board. The fiscal 27 allowance increases by $7 million to a total of $366 million across these offices, and that's almost entirely in special funds. Turning to fiscal 26, there were 2 legislative additions last year. $350,000 was added to the HSCRC budget for pass-through funding through CRISP for services from Dr. First. This funding has been spent in fiscal 26. The other legislative addition was a grant for the Maryland Patient Safety Center. Last year's BRFA eliminated the annual $1 million mandate for the center, and so this add provided $200,000, and that has also been fully spent in fiscal 26. There is one proposed deficiency, and that provides $6.3 million under MHCC to account for additional revenue from the vehicle registration surcharge. Legislation from 2024 increased the surcharge and required increased distributions to the Shock Trauma Center and the Maryland Trauma Physician Services Fund, and so the deficiency is split between those 2 uses. The Shock Trauma Center used to receive an annual operating grant through the MEMSOF Special Fund. This was planned to end in fiscal 2025. However, reported actual spending still included the $3.7 million MEMSOF distribution. And so MHCC and DBM acknowledged this was an overpayment since the center now receives direct vehicle surcharge distributions. And so MHCC is asked to discuss the timeline for recovering the overpayment. Turning to the fiscal 27 allowance, Exhibit 1 on page 4 shows an overview of spending. The largest component is $130 million for the uncompensated care fund. It accounts for a little over a third of the budget. This fund is distributed by HSCRC to hospitals for care that the hospitals do not receive compensation for, like charity care, financial assistance, and bad debt. I'll also highlight that just over $50 million in operating expenses are supported with user fees, and so the bar shows that HSCRC accounts for a little over half of those user fees. And as I mentioned in the Medicaid analysis, HSCRC collects hospital assessments, including significant amounts that support Medicaid expenses, in addition to the fees it collects to support its own operations. And so considering the increased federal scrutiny and on provider assessments and potential implementation changes to meet uniform and broad-based tax requirements, HSCRC is asked to comment on how hospital assessments may change in the future. Exhibit 2 shows proposed budget changes from fiscal 26 to 27. The largest driver of spending growth is a $10 million increase for the consortium on coordinated community supports. This is after accounting for a $20 million reduction that is contingent on a BRFA provision that would reduce the funding mandate for the consortium. Personnel costs also grow in part due to the transfer of 4 positions into the commissions, mainly for HSCRC. There are 2 budget discussions that start on page 7. The first discusses a special fund reduction of $1 million that is contingent on a proposed BRFA provision. The BRFA provision waives the requirement that $8 million in cigarette restitution fund supports the Community Health Resources Commission's operating grants. This would be waived in fiscal 27 only, and the CRF support would be transferred to Medicaid that would then provide general fund relief. MCHRC operating grants would be supported with fund balance from the Commission's fund or special fund. The fiscal 25 closing balance was just over $2 million, and so DLS recommends reducing the CRF support by another $1 million. That would provide $2 million in general fund relief under Medicaid. This action would be a language amendment under Medicaid, and so we'll present that as part of the decision process. There is also a technical recommendation included in this analysis to amend the contingent language to more closely align with the BRFA provision. The second budget discussion relates to uncompensated care. If you look at Exhibit 3 on page 8, this shows trends in uncompensated care since 2010. It's shown as a % of patient revenue. The main takeaway here is that uncompensated care decreased significantly following ACA implementation in 2015 and on. And so with recent federal actions like the One Big Beautiful Bill provisions, that will lead to Medicaid disenrollments and then changes to the premium tax credits available through the exchange. There's expected to be increases in uninsured and underinsured Marylanders, and that would result in more uncompensated care. Moving to the key observations section, that begins on the bottom of page 9. The first item covers Maryland's recent activities related to the end of the total cost of care model. This ended on January 1st of this year, and the new AHEAD model began in 2026. These are agreements with CMS that set the parameters for Maryland's hospital rate setting system, and they seek to control growth in healthcare costs and improve population health. Maryland met every performance benchmark under the total cost of care model for 2024, and the results are shown in the analysis in Appendix 2. In the past year, there was a lot of work done by HSCRC and MDH to renegotiate the AHEAD model with CMS, and an amended agreement was signed on November 12th. Under the new agreement, HSCRC will continue to set global budget revenues and have rate-setting authority for commercial payers, Medicare Advantage, and Medicaid, but following a 3-year transition period, the federal government will take over rate-setting authority for fee-for-service Medicare. Maryland's required fee-for-service Medicare savings target is $460 million by plan year 7 in 2032, and there are cumulative cost growth requirements for Medicaid and Medicare Advantage of $870 million over that same period. The agreement still includes targets for primary care investments and quality and population health targets, which were included in the original agreement. One new component is that Maryland must select at least one healthcare initiative related to consumer choice and one related to competition. The list of options is shown on pages 10 and 11. And then to address issues related to AHEAD model implementation, the governor established a multi-agency regulatory working group, and that group released a work plan in October and has made recommendations related to cost shifting and Medicare Advantage policies. One initial task will be recommending which choice and competition initiatives the state should select. One of the policy recommendations made by the working group and approved by the governor is to spread the state's required cost savings across multiple, to assist in spreading the state's required cost savings across multiple payers is a cost-shifting proposal to increase commercial hospital rates by $87 million annually from 2028 through 2032. HSCRC is still determining how that rate increase will be applied. Last year, there was budget language in the fiscal 26 budget bill that restricts funds pending a report from HSCRC on efforts to align incentives between Medicare Advantage plans and hospitals under the AHEAD model. HSCRC submitted this report in December and included the working group's proposal for MA market stabilization. Page 12 summarizes the report, including some past efforts to distribute funding to Medicare Advantage plans to facilitate access and partnerships with hospitals. Last year, HSCRC considered an alignment program to tie population health improvement to financial assistance for Medicare Advantage plans through differential hospital rates, but this initiative is not moving forward. Instead, the working group made a recommendation to provide financial assistance through reduced hospital costs to MA plans, specifically ones that mostly serve beneficiaries in Maryland, enroll a certain share or number of their beneficiaries from low-income counties, and meet certain quality requirements by 2028. Based on HSCRC's response to the budget language, DLS determined the report to be in compliance and recommends the release of withheld special funds and will process a letter if no objections are raised at these budget hearings. The rest of this key observation covers primary care initiatives under the AHEAD model. This includes the continuation of the Maryland Primary Care Program through calendar 2028. At that time, CMS will evaluate whether the program should be extended. There are also new initiatives to offer incentives for advanced primary care. This includes a new Medicaid path that would incentivize providers offering advanced primary care to Medicaid participants. And there's also a quality improvement path that aims to expand primary care in underserved areas. Legislation from last year also established the Population Health Improvement Fund that is supported with hospital assessments and will be used to reduce the incidence of chronic disease. To continue monitoring these initiatives, DLS recommends narrative requesting a report from the Health Department and HSCRC, including an evaluation of the Maryland Primary Care Program over the entire total cost of care performance period now that that model has ended. The second key observation has to do with the consortium, and it begins on page 15. The consortium was created as part of the blueprint to meet student behavioral health needs. Exhibit 4 shows the current mandated funding levels, including the proposed reduction in this year's BRFA. That would reduce the mandate by $20 million on an ongoing basis beginning in fiscal 2027. This reduces the mandate from $100 million to $80 million. Exhibit 5 on page 19 shows consortium grants by local jurisdiction. This shows the initial announcement of $99 million in grants that were awarded for fiscal 26, but this was later updated to $96 million in total awards. Consortium grants support various levels of services for prevention, early intervention, and treatment. There are also 3 different types of grants provided by the consortium. The first could be a community supports partnership grant to local behavioral health authorities, local health departments, or local management boards, and that's to oversee the funding and allocate funds to service providers. There can also be planning grants for counties that are starting up their community supports partnerships, and then there can also be grants made directly to service providers in a local jurisdiction. Appendix 3 shows this funding detailed by grant type. And so when comparing each jurisdiction's share of consortium funding to their share of students who are eligible for free and reduced price meals, these measures generally align, but there are a few counties that make up a larger share of free and reduced price meal enrollment, but then receive a smaller share of consortium grants. And so considering the discrepancies, MCHRC is asked to discuss how the grant-making process considers financial need and social determinants of health when deciding the county allocations. For the next round of consortium grants in fiscal 2027, an RFP was issued in December, and the consortium expects to announce grant awards this spring. I'll note that the consortium is estimated to have $16 million in remaining unspent funds at the end of fiscal 26, but expects that those funds would revert back to the Blueprint Special Fund at closeout. And so with the BRFA provision, this would allow for $80 million in grants for fiscal 27. The final key observation discusses the Prescription Drug Affordability Board. The board is authorized to conduct cost reviews and establish upper payment limits through regulation for drugs purchased by or on behalf of a unit of state or local government, including employee plans and Medicaid. The list on page 21 shows requirements for drugs that the Prescription Drug Affordability Board can identify for cost review. The board first identified 8 prescription drugs that met these requirements, but then narrowed the list down to 6 drugs. Staff members have presented findings and policy recommendations from the cost review studies for 4 drugs that treat diabetes. The studies for Farxiga and Jardiance were presented in July, and then studies for Ozempic and Trulicity were presented in November. The cost review studies for the final 2 drugs that treat autoimmune disease are expected in early this calendar year. And then all 4 drugs presented last year were found to create affordability challenges, and the board recommended starting the process to set upper payment limits for Farxiga and Jardiance. The board also recommended considering non-upper payment limit policy recommendations or options. The board is creating a methodology for upper payment limits for those 2 drugs, and the board also indicated that it aims to streamline the upper payment limit process. The board should discuss the timeline for implementing upper payment limits and other recommendations for Farxiga and Jardiance and how it would streamline this process. The board should also included recommendations in its annual report, and that included encouraging prescription drug price transparency. Since this is also an option for choice initiatives under the AHEAD model, the board is asked to discuss if it's collaborating with the working group to consider advancing this as one of the state's chosen initiatives. Page 23 reflects the 2 recommendations that I mentioned through this presentation. And so with that, I'll conclude my remarks. I'm happy to answer any questions.
Seeing no questions? Seeing no questions at this time, we'll move towards the agency responses.
Mr. Chair, if you're good with it, I'll start. Good afternoon, Chair McRae and members of the committee. Grateful to be here today. For the record, I'm John Crom, Executive Director of the HSCRC. As always, special thanks to Ms. Braun for her thoughtful analysis. I know she does a tremendous amount of work summarizing the work of the year. The FY27 HSCRC budget allowance will allow the agency to continue HSCRC's core functions, which focus on healthcare affordability, healthcare quality, and health equity. As a top priority as last year, we continue to work closely with hospitals, other state agencies, and stakeholders across the healthcare system to support a successful transition to the Achieving Healthcare Efficiency Through Accountable Design, or AHEAD model. AHEAD provides a strong foundation for continued progress toward accessible, affordable, and high-quality care for all Marylanders, really building upon the successes of the total cost of care model to reduce healthcare cost growth, improve health outcomes, and ensure more robust investments in population health and primary care. And on November 12th of 2025, Maryland and the Centers for Medicare and Medicaid Services signed an amended and restated state agreement. So this is the second kind of round or second iteration of the AHEAD model agreement for the next 10 years. The AHEAD policy decisions will have system-wide effects across the healthcare continuum and require thoughtful, coordinated, and comprehensive policy decisions. The work of transitioning to AHEAD has and will continue to involve extensive technical work with the Centers for Medicare and Medicaid Services, our federal partners, to evolve the hospital global budget system and to meet the new AHEAD requirements. And our work plan for the year really involves a re-examination of almost every one of our financial policies within the agency. We'll be doing significant engagement with and participation from stakeholders across the healthcare sector. And then, as Ms. Braun described, there will be a lot of interagency cooperation and collaboration under the work of the multi-agency regulatory work group. I want to take the bulk of my time to respond to DLS's observations and questions. The first request was for HSCRC to comment on how its implementation of hospital assessments may change due to the OBA provision on uniform and broad-based tax requirements. I will say, as you heard from the Medicaid team, this is a little bit under flux, right? So CMS issued its final rule on Medicaid provider taxes on January 29th of 26. Per the final rule, hospital assessments such as Maryland's Medicaid deficit assessment will need to come into compliance by the end of FY 2028. Maryland's current assessments, including the Medicaid deficit assessment, are under CMS review, and MDH has requested direct technical assistance from CMS to determine if changes will be needed to maintain compliance once the requirements go into effect. So HSCRC staff are working closely with the Medicaid team at MDH to determine what, if any, changes might be necessary and to ensure that the assessment is broad-based and uniform. Second, DLS recommends that MDH submit a report in collaboration with HSCRC on the implementation of new primary care and population health initiatives, including the Medicaid Advanced Primary Care Program, new paths under Medicare primary care efforts, the Population Health Improvement Fund, and the Maryland Primary Care Program, or MDPCP. HSCRC concurs with this recommendation and will work and plan with MDH for that work and reporting to continue. Finally, DLS recommends the release of $250,000 in special funds for HSCRC based on our submission of a report on incentives for MA plans under the AHEAD model. HSCRC thanks DLS for its review and for the recommendation to release the funds. So I'm happy to answer any further questions that you might have.
First, I just want to lean in and say thank you for helping me figure out the maternal health stuff over there at the agency. Senator Jennings.
So let's talk about Medicaid Advantage. I heard this summer, I think it was United and Aetna got out of the market, which I think dropped, what, 35 and 13 clients, 1,000 each. Where do we stand with that? I see this thing collapsing, and I don't see a solution coming.
So the multi-agency regulatory working group just made a recommendation to the governor. The HSCRC voted on it. What that solution does is there's a component of the federal reimbursement algorithm for Medicare Advantage plans. So again, Medicare Advantage plans being primarily regulated by the federal government. It's a federal program, right? But within that reimbursement structure, doesn't anticipate that Medicare fee-for-service hospital rates will be managed in the way that it is in Maryland under global budgets, right? So what we did was we calculated kind of roughly what is attributable to not having that accounted for in the federal reimbursement structure. And we create a mechanism to shift those costs in the form of essentially a discount on hospital rates for Medicare Advantage programs. That is going into effect in 2027. The reason for that time frame is because that does have a direct impact on particularly commercial plans in the commercial market plans in the market in Maryland. So we want to make sure that there aren't any kind of immediate rate impacts that are unintended from that process. So that work is underway now for us to determine what those discounts are going to look like. And we just released memos to letters to the Medicare Advantage plans in Maryland that are going to qualify for those discounts. So we will be working with them over the next few months to determine essentially what they can.
So when would they take effect in 2027?
So they would take in, they would
January
come,
1?
January 1, 2027. Yeah.
So we have to wait 9 months. And I mean, I'm asking this is, you know, I just hear it around the state. You know, as we're down here, we've got, you know, all these insurance companies, everything's coming in our offices talking to us saying, look, we're on the verge of collapsing. You know, we're hemorrhaging money. We can't handle this. And I know a couple years ago, I think under the Hogan administration, they kind of had a bridge. Is there anything to kind of bridge those that are left to get us to 2027 for 9 months? Because I don't know if some of these companies are going to be able to hold that long. I mean, if they're hemorrhaging that much money, I mean, what are you hearing in the market?
Yep, so understood. So again, we don't directly regulate the Medicare Advantage plans, but when we went through the process, we did hear from a number of plans that were supportive of the 2027 timeframe, and largely that was because they did recognize that the only mechanism within the HSCRC that we have available to us is an increase in hospital rates, right? And so those rates, I think they did recognize, right, that would cause rate increases across other markets. So there are other market impacts for those rate increases. So there's a budgetary impact, there are, you know, commercial market premium impacts, et cetera. So I think that was really the driving impetus between, you know, on that timeline and time frame, because that allows for those commercial market premiums to be adjusted and run through the market.
Is this January 1st set in stone?
It is set in stone for the HSCRC policy, yeah. Yes.
So these, I think it's what, Care First Hopkins are still in the market. They know that January 1 that they will be getting this lower rate.
Yes, sir. Yes, sir.
Okay.
We have to calculate the rates, right? So there's months of work in front of us to figure out how the rates are going to be determined, yes.
Okay. Thanks, Mr. Chair.
Thank you.
Good afternoon, Chair, members of the subcommittee, and special thanks to Ms. Braun. This is my first time going through this process, and so I was really impressed with the DLS analysis. And we also want to thank the Governor, Department of Budget and Management, and continue to work with the subcommittee on all of our priorities and your priorities. So you have our presentation materials. I wanted to briefly just talk through MHCC and some of our priorities going forward. So MHCC is a 15-member independent regulatory commission that works to improve quality, control costs, and expand access to care through data, public reporting, health planning, and regulation. Our work is carried out by 4 policy centers and an operations team. And some of our major areas of responsibility include oversight of the all-payer claims database for the state, conducting many of the studies you're all familiar with the legislature related to mandated benefits and costs. We also designate and oversee CRISP, the State Designated Health Information Exchange and Health Data Utility, and regulate health information exchange and electronic health networks. We operate and update a consumer-facing quality website that helps Marylanders choose where to get care. And we have very, very specific health planning functions. I think many of you may be familiar with Certificate of Need, certificates of ongoing performance related to cardiac care, and most recently we started overseeing and monitoring skilled nursing facility acquisitions. And also we oversee the trauma fund, which was mentioned as part of the analysis as well. And as we move forward, we're excited to also work on efforts in partnership with the other agencies in the multi-agency regulatory group that Dr. Crom had just mentioned, related to setting primary care targets, workforce strategies, post-acute care related to the CMS Ahead model, and also we're partners with MDH in the Rural Health Transformation Program. So I started in August, and since then we've refreshed some of our strategies going forward. And so I wanted to briefly walk through those priorities. And they're access, reducing disparities, promoting value, and operational excellence. So first, access. We're focused on strengthening primary care, addressing workforce challenges, and improving coverage and utilization policies. This includes advancing primary care investment targets through the Ahead model, developing a statewide workforce strategy, and working with state partners on telehealth policy, electronic use of prior authorization, and data integration to support eligibility and coverage continuity. Second is reducing disparities. MHCC is using data and health planning tools to advance health equity. We're identifying high-performing providers, serving underserved communities, and improving the connections between medical and social services, updating certificate of need criteria to promote new entrants into underserved areas. And we recently awarded grants through the Trauma Grant Program to support community-based initiatives in underserved areas as well. Third is value. Our work focuses on improving quality, safety, and competition in the healthcare system. And this includes advancing quality improvements in long-term care, increasing the use of MHCC's public quality data, improving data collection tools, and strengthening transparency on mergers, acquisitions, and ownership changes. And finally, operations. We are strengthening MHCC's infrastructure, data systems, and communication capabilities. It includes streamlining internal processes, enhancing our data hub, and launching a redesigned website in the spring, and also building staff capacity to address emerging policy challenges. So looking ahead, MHCC is excited to continue this work while supporting major initiatives such as the Ahead model, the Rural Health Transformation Program, and any policy priorities that come out of this legislative session. Before closing, I wanted to briefly address the question raised by DLS related to the timeline for recovering the $3.7 million distributed to the Shock Trauma Center. This is now taken care of as of February 2025. MHCC, the Comptroller's Office, and MBA coordinated to fully recover the $3.7 million transferred in error to Shock Trauma and ensure all documentation is accurate, reflects the correction, and reconciles all payments. So with that, thank you, and I'd be happy to answer any questions.
I was texting back with one of our friends, and we were going to mess with you a little bit because it's your first time at the desk going up to 3.5. I'm going to let it ride, though. Okay. Thank you for your leadership. Mr. Luckner.
Good to see you again, Mr. Chairman. Mark Luckner, Executive Director of Community Health Resource Commission. Congratulations again. Yeah. You always remember your first. Mine was a couple of years ago. I guess I'm trying to retire. I'd like to begin my testimony. I'll be very brief, and I'll get to Ann's thing. First, I want to thank the governor for the fiscal 27 allowance. We appreciate every single dollar he gives us. Second, I'd like to thank Ann for her analysis, and in particular, we were pleased to host Ann and about 6 or 7 other staffers from the Department of Legislative Services this summer. They did 2 site visits with us out across the state, and so she's more than just the numbers and the analysis. She took the time to accept our invitation and come see programs, and I would extend that invitation to members of the General Assembly this interim. And then third, I want to thank this subcommittee in particular. Our office has grown over the last couple of years, and we've been pleased to stand up 2 statewide programs, and we couldn't do it if it wasn't for the continued outstanding support of the Maryland General Assembly. I want to give Lorianne Moss a shout out. She's with me. Can Lorianne stand for a second? She's been with me every step of the way. Her anniversary, her 6-year anniversary was in January. She started just before COVID came. With Lorianne's assistance, our agency has grown a lot. So Lorianne, a lot of other people back in the office, I just want to give them a shout out. Our agency was established in 2005. I happened to work on the bill at that time, and I've been here in this role in 2009. We now have 985 grants that have been awarded, $396 million, and they've served 1 million Marylanders. So we're happy about that, but we think the best is yet to come. We have 3 programs. First, our annual program, and I'll take your the suggestion about increasing the deficit from $1 million to $2 million. As long as we can use our fund balance, it's okay. It's fine, no problem. But I want to point out that you said that was in fiscal 27 only, so no deal in 28. It's a one year, okay. The second program is, I want to make that point. The second program, right, sorry, the second program is the Maryland Health Equity Resource Act, which is 12 grants $59 million. They're in year 2, they're going to year 3. It's a great program. Ann didn't touch on the analysis, so I won't get into that second program. Great program. It's a great program. Senator Hayes is a sponsor. Happy to have folks come out and see that. 12 grants across the state. And then third, which we'll talk the most about, the Consortium on Coordinating Key Supports, which is in the blueprint bill. That has over 100 grants totaling $97 million, and they have served 109,000 children across the state, and they're on pace to exceed 160,000, which grows from last year's overall figure of 135,000. The numbers of children served are important, but perhaps even more important are some of the outcomes that are being achieved by these programs across the state. 90% satisfaction rates, 90%. The children and parents that are receiving services, 9 out of 10 folks are satisfied. 8 out of 10 children that get these services demonstrate an improvement in the desired skill. So I think I would close my remarks by pointing out that when you think about the Community Health Resource Commission, I'd ask health equity, reducing disparities, and this consortium is hope and resiliency for our children. And with that, I'd be happy to answer any questions. It's good to see you again, Mr. Chairman.
See no questions, but I was upset you didn't say that I went out to a visit too.
Well, that was last interview. I'm going to get you back this spring.
My guy. Yes, sir.
Great. Chair McCray, members of the subcommittee. My name is Andrew York, and I'm the executive director of the Maryland Prescription Drug Affordability Board. I wanted to thank Ms. Braun for her amazing analysis as always, and thank the state for the allocation. We are a small independent agency that was created in 2019 with the exclusive mission of making prescription drugs more affordable for Marylanders. Your budget allows us to complete that mission. I was going to just briefly dive straight into the questions from Ms. Braun. So first, this is an exciting time for the board. They are on track to complete the first round of cost review studies for these 6 drugs. In terms of those timelines, we expect the first 2 drugs mentioned in the question, Farxiga and Jardiance, to be completed this spring. The final step for these drugs is for us to publish a cost review study report, the board to approve non-upper payment limit regulations, and then also within our authority we can set upper payment limits. So if they decide to do so, they would do that through a proposed rule. The rest of the drugs we hope to close out through the kind of mid to late this year. And that goes into the streamlining of the process, which was the second question. Our board is currently getting public comments on how to make this at kind of an annual cycle. I think that's the goal moving forward. Select the drugs at the beginning of the year, have the process closed out and everything done by the end of the year, and then make that an annual cycle. So we've received public comments on how to improve that process, and we'll be updating our regulations, proposed regulations probably sometime this spring, with them to be completed in the fall, all to be implemented starting in 27. And then finally, there was questions about how the board is supporting the multi-agency group. The board is very excited about the interest and focus of drug transparency as part of the AHEAD model. We are providing technical and staff assistance to the multi-agency team, and very much think that there is kind of alignment and opportunity for collaboration in that space. So we are helping that agency and look forward to continuing to work with them. Thank you for the subcommittee's support, and I'm available for any questions.
Seeing no questions, I wanted to thank each and every one of you all for your serve. Oh, Senator Augustine.
I just wanted to say that as far as the consortium, I have visited in my district, and it is very, very impactful. And I just really am very, very supportive of how it's helping our children and their families. And I just want to make sure to communicate that. Thank you.
Thanks.
Yep. You just made me reflect a little bit. Just thankful for each and every one of you all in reference to how you make sure that we understand the work that you all are doing. And I truly believe like the visuals are very helpful. Ben Steffen was a great partner, so I look forward to developing that same type of relationship. You should thank us. We did not haze you for your first time. But Director Chrome, I know that you heard Senator Jennings very quickly, but just to reiterate, like the Medicare Advantage is very important to us and just figuring that puzzle out. You already know the Baltimore region, the impact, some of the challenges that I've had in the past, but just want to say thank you for being a partner. Mr. Zucker, Senator Zucker.
Mr. Fine, I've heard you call me worse. I just wanted to echo the Medicare Advantage piece too. Deep concern, and I know it's an important program, so make sure it gets to where it needs to be. Thank you, appreciate it.
I forgot to thank Miss Ann Braun. This is our last one, so just want to say thank you, Miss Braun. Oh. And colleagues, we do have some public testimony. David Efron, James Gannon, Ann Geddes, and Kyle Remick.
I guess so. Good afternoon, Chairman McCray. It's all right if I start? Yeah, thank you. And committee, my name's Jamie Gannon. I'm the Trauma Program Manager at Sinai Hospital. Trauma centers must maintain readiness 24/7, 365, not for convenience, but because injury does not wait. At Sinai alone in fiscal year 22, cost to maintain the required specialty readiness exceeded $21.5 million. These are fixed, non-negotiable costs. At the same time recently, we are seeing a growing percentage of undocumented and uncompensated trauma care. Trauma centers are required to treat every injured patient regardless of insurance or ability to pay. As the number of uninsured or underinsured patients increase, reimbursement often falls short of the cost of providing highly specialized trauma care. The Trauma Physician Services Fund was created because trauma readiness is uniquely expensive. A state commission in 2023 confirmed that these costs have risen dramatically and previous funding mechanisms were not keeping pace. Investing in trauma care saves lives and saves money. A peer-reviewed study published in 2024 showed that reducing statewide trauma mortality preserved an estimate of $4.3 billion in lifetime personal income and $508 million in tax revenue, illustrating that trauma system funding is an economic return, not just an expense. In addition to national trauma demonstrating economic return, published research examining statewide trauma systems, including work that I co-authored, reinforces coordinated trauma networks with sustained funding are associated with measurable improvements in survival and system performance. These systems require stable funding to function. At Sinai, we are using the grant funds from the MHCC to prevent injury before it happens, addressing elderly falls, which cost more than $50 billion annually nationally, and distributing gun safes and gun locks to prevent pediatric firearm injuries, such as 6-year-old Lachelle Lee IV in Montgomery County and 9-year-old Ava Sewell in Baltimore City. We are also strengthening trauma quality and workforce training to report measurable outcomes to the MHCC. If the committee allows the funds to be redirected or reduced, we risk weakening Maryland's trauma safety net. Readiness must be constant. The next injured Marylander may be sitting right in front of me. We respectfully urge preservation of the Trauma Services Fund. Thank you.
Hope you didn't use my time. Thank you. Thank you for the opportunity. My name is Kyle Remick. I'm a trauma surgeon in Western Maryland. I'm also the current chair of the Maryland Trauma Center Network, known as TraumaNet. And I appreciate the opportunity to also speak in favor of increased funding for the trauma program in the state. We know that we have one of the best trauma systems in the country and the world. This costs money. I have a CFO that reminds me of that fairly regularly. Trauma is generally undercompensated, under reimbursed, and sometimes not reimbursed at all. Many trauma centers, if not most, run in the red usually for their trauma services and have to be offset by other areas of the hospital. When I also still work in the trenches, so I take care of trauma patients. when I see Marylanders that are injured and their family members, they generally say that they want the best trauma quality care available anywhere. And they rarely ask how much it costs. I don't know what their thoughts are on the cost of trauma care prior to them arriving and being injured, but I do know what they say afterwards. Marylanders actually expect the best trauma care in the country and the world. So we do support the increased surcharge. The trauma fund gets about $2.50 or $6.50 up from $2.50 of the increased surcharge. And in the written testimony that TraumaNet has provided are some of the reasons of what this goes towards. Generally, increasing numbers of trauma patients, increased amount of types of equipment and technology that needs to be purchased, increased on-call for physicians. And in general, in the end, I want to say that Marylanders expect equitable care, whether they live in Baltimore or they're injured in Baltimore, injured in a rural area, and we need to try and provide that for our citizens. Thank you.
Thank you, Mr. Chair and committee members. I'm Ann Geddes. I'm the Director of Child and Older Adult Policy at Mental Health Association of Maryland, here to support full funding for the CHRC and the Consortium on Coordinated Community Supports. You know this, the need for quality mental health and substance use care has never been greater. All indicators show that the mental health of children and youth is worse now more than ever. And there are real benefits to providing behavioral health services in schools. When students are referred for behavioral health services outside of schools, only about 3/4 actually attend one session and only 1/2 attend 4 sessions. Families face multiple barriers trying to follow through with referrals to outside providers, and only schools can engage in those prevention and early intervention efforts before a problem rises to the level of needing formal treatment. Mark Luckner cited the data. The consortium this last year has just really outstanding results. But the BRFA, again this year, proposes to cut funding for the consortium by $20 million annually. The cut would have a devastating impact on children and youth. Over the last 2 years, consortium grantees have hired staff, developed programs, and formed close working relationships with school staff. Now many would have to close their doors and investments made thus far be lost. Because of the dramatic need for school-based behavioral health services and because of the overwhelming success of consortium grantees, we ask for full funding for the CHRC, and thank you for your support.
Thank you very much, Chairman McCrary and the committee. My name is Dr. David Efron. I am the Chief of Trauma and Medical Director of the R.E. Cali Shock Trauma Center at the University of Maryland. Dr. Scalia sends his absolute best and regrets not being here, being out of town. We'd like to thank you for the opportunity to speak and thank you for your continued partnership in sustaining Maryland's world-renowned trauma system. The Shock Trauma Center is the state's primary adult resource center. It is a core element of the Maryland's integrated emergency medical services system. We are the state's only freestanding trauma hospital caring for more than 6,200 critically ill and injured patients each year with a 96% survival rate. That equates to 6,000 lives saved. 2 particular statistics I'd like to share. A total of more than 1,600, or 26%, come from the state's largest city, Baltimore. We are truly a community access hospital. That means 74% come from the rest of the state. And with that, 30% of our admissions are transfers from other hospitals throughout the state, including other trauma centers, in order to provide the highest level of care. And we function as a backstop for the Maryland trauma system. Thanks to the dedicated funding, we have made significant measurable improvements that benefit the entire state. We are now able to fully staff our full complement of trauma operating rooms. All 8 dedicated trauma operating rooms now have available consistent staffing across nursing, anesthesia, and surgical disciplines. This has had a tremendous ripple effect on our downstream movement of patients to ultimately discharging. These efforts have enabled us to accommodate an additional 160 interhospital transfers last year that we wouldn't be able to before. This represents a 64% reduction in lost intrahospital transfers, meaning that the patients who need shock trauma are getting to shock trauma. And with this, we've been able to keep our doors open for everyone. The ebb and flow of emergencies will occasionally temporarily cluster the needs for care. We too reach a limit of space to safely care for these patients. This in our world is described as capacity. While we maintain well below the regulated 5% of time, we have further reduced our time spent on capacity by 62%. In short, Marylanders have invested in us, and it is working. This support enhances readiness and efficiency, which has streamlined access and optimized survival. Any one of us, of our family members, could need trauma care at any moment: a car crash, a fall, a violent injury, a medical emergency, and we must have the ability to say yes. Recognizing the difficult choices that are made regarding funding, the investment that the General Assembly and Marylanders have made directly supports a life-saving promise. Shock trauma and the Maryland trauma system will always be ready when they are needed. We are grateful for that trust, and we have honored it with real measurable improvements in access, readiness, and patient survival. Thank you for your time and for your ongoing commitment to the Maryland trauma system. I'm happy to answer any questions.
Good afternoon. My name is Justin Graves, and I'm the Director of Trauma Programs at the RM's Cali Shock Trauma Center. I oversee our prevention and community programs. Because of your support, I'm pleased to share some of the impacts of this significant expansion in trauma prevention and education efforts across the state. Last year alone, our programs reached more than 22,000 Marylanders across 17 counties. Stop the Bleed is a great example. In FY25, we trained over 10,000 Marylanders to control life-threatening bleeding, including thousands of students and nearly 1,000 school staff. Working with our partners at TraumaNet and the Maryland State Department of Education, we have been advancing efforts to incorporate Stop the Bleed training into the health curriculum for all Maryland high school public students. Recently learned this week, I'm very pleased to share that the State Board of Education has approved that language, and so this will be the new standard going into effect for all high school students for the 27-28 school year. Violence prevention remains another critical priority. Last year, 643 victims of violence were screened at the bedside, and 57% of those chose to engage in wraparound services designed to reduce the risk of retaliation or re-injury. In October, we opened Maryland's first trauma recovery clinic, bringing medical care, mental health services, legal support, case management all together in one place for our patients. We're also working upstream through our SMARTER program, Saving Maryland's At-Risk Teens, which partners with the Department of Juvenile Services and Baltimore City Schools to engage young people after first gun-related offense. And Senator McCray, just a personal shout out to you, and thank you for taking the time to come and speak with our participants in that program. It meant a lot to them and to our team. Finally, falls remain the single largest driver of trauma admissions, accounting for 43% of our patients. Through our fall recovery and prevention program, we are working with older adults across Maryland to prevent repeat injuries and to help them remain safe and independent. These programs demonstrate the impact that legislators' investment not only treating trauma but preventing it. Thank you for your continued support and time today.
Senator Jennings.
Thank you. So right now we're getting beat up on the tag fees. And I've tried to remind people that there's two different fees that are out there now. One is your car registration, which is for highway user. The other one we passed, I guess, was it 3 years ago to the trauma side. And that's the one I want to kind of talk about because that one's much lower. And the doc in the middle, did you say how much and I'm sorry, I got to go down memory lane. I don't remember how much we raised. The council knows.
I don't know how much we raised exactly. Do you guys have that?
I believe it went from $2.50 to $6.50.
Right.
So we got an increase of $4.
An increase of $4
per registration.
And that is what has made the difference. Dr. Efron on the left. Sorry, I can't see because of the
It's okay.
podium. Usually I could because you're one of the tallest guys I see. Usually I see him in pink scrubs when I'm down at the trauma facility. And that is what has enabled you to go from, what was it, 6 ORs to 8 now, you said?
Yeah, we were running usually around 5.5 to 8 ORs. Prior, we would mostly, the average was about 5.5. Some days it was less. 6 was usually the most we could do before all this.
It is because of this $4 registration fee increase.
Correct.
Okay, thanks.
Seeing no further questions, just want to thank you all for your service to the great state of Maryland. And colleagues, we do have a couple other folks that are testifying in reference to this respective agency. We have Alyssa Saunders. and Morgan Mills.
All right. Good afternoon, Chair McCray and members of the subcommittee. My name is Morgan Mills. Here today on behalf of both the Horizon Foundation of Howard County and the National Alliance on Mental Illness, or NAMI Maryland. Horizon Foundation is the largest independent health philanthropy in the state of Maryland, and NAMI Maryland represents 60,000 folks across the state who are living with mental illness, as well as their loved ones in the greater community. We are here to ask you to fully restore the $20 million or 20% cut to the consortium on coordinated community support. This proposed budget would cut school mental health funding from $100 million to $80 million. The consortium is a critical program that was established through the Blueprint for Maryland's Future to meet our kids where they are and deliver comprehensive mental health services to them. We know that early intervention is extremely important for mental health, and these cuts could lead to about 27,000 students statewide no longer being able to access these services. The consortium is working. Last year, the funding supported over 136,000 students statewide and resulted in improved mental health outcomes for nearly 80% of those served. I want to point out that this committee worked tirelessly last year on this very same issue. Last year, we were facing an even bigger proposed cut. The proposal was to cut the original funding of $130 million down to $40 million annually. And this committee right here believed in these services enough that you fought to retain that $100 million funding level. So we are asking you, please do not cut this program that is serving our most vulnerable youth. We know there is a youth mental health crisis and it needs to be addressed, and cutting this would be absolutely detrimental. Thank you so much.
Thank you. I agree with everything she just said. Chair McCray and members of the subcommittee, my name is Alyssa Sanders. I'm the Director of Advocacy at EveryMind, a mental health nonprofit. And for nearly 70 years, EveryMind has walked alongside Maryland families in their hardest moments, providing prevention, early intervention, and life-saving mental health care. I'm here today to urge you to amend the budget and restore the proposed $20 million cut to the consortium for coordinated community supports. A 20% cut to school mental health funding is not trimming a line item. It is pulling support away from children in crisis. EveryMind's clinicians, case managers, and mentors are trusted partners inside school communities, including in 13 consortium-funded schools. They provide therapy, mentoring, case management, and support for families and staff. This funding doesn't sit in a budget line. It walks school hallways and sits beside students when they are at their lowest. Nearly 40% of Maryland high school students report feeling persistently sad or hopeless. We all know that suicidal ideation among youth has surged. These are not abstract numbers. These are students sitting in classrooms right now, carrying trauma, anxiety, and depression, often silently. For example, I'll share one of our students' stories. She came to us angry and repeatedly was being suspended, acting out because there was trauma at home. Others saw behavior, we saw pain. With consistent mentoring from a trusted adult who showed up every day, she's gone this entire year without one suspension. Her grades are up. She's using her words instead of her fists, and for the first time, she's talking about her future. That transformation happened because funding allowed a trained adult to be there consistently. Now multiply her story by thousands. You have the power to choose differently. You did so last year. Restore this funding, protect these services, protect our children. Thank you.
Senator Augustine.
Thank you, Senator McCray. I just want to thank you all for supporting the students in my district, the families, and you really, really have made a difference in their lives, and I'm grateful. Thank you.
We're grateful for you too, Senator Augustine. Thank you.
And thank you both for your advocacy. Colleagues, at this time, first I just want to make sure, is no one else that signed up to give testimony for this respective agency? Is it still out there? No. Colleagues, at this time, we'll move to the next agency, and that is the Department of Human Services, Child Support Administration. We'll ask for Mr. Connor Brown.
Thank you, Mr. Chairman. Good afternoon. My name is Connor Brown, Policy Analyst with the Department of Legislative Services, here to present the fiscal 2027 budget analysis for the Department of Human Services Child Support Administration, or DHS CSA. To begin, on page 1 of the analysis, the fiscal 2027 budget for CSA increases by $23.9 million, or 21.3%, to $136.1 million. On page 2, there are 5 proposed deficiencies in CSA, totaling $3.7 million. The largest, making up almost half, is for the Constituent Services Call Center. As was discussed in the DHS administration analysis, this is part of a larger realignment that overall decreases the fiscal 2026 appropriation. There's also a proposed deficiency of almost $1 million for child support services in Baltimore City, which are handled by a private contractor. Although a new contract was approved by the Board of Public Works back in June of 2024, DHS indicates that the contract amount was not fully accounted for in the fiscal 2026 budget formulation process, including a one-time transition fee that was incurred in fiscal 2025. DHS should comment on why the portion of this shortfall that related to the transition fee from fiscal 2025 was not paid using the fiscal 2025 appropriation, or reported to the Comptroller's Office at closeout if there was insufficient appropriation. On page 4, Exhibit 1 shows an overview of agency spending in fiscal 2027. Moving on to page 5, Exhibit 2 outlines line item changes in the fiscal 2027 allowance compared to fiscal 2026. One of the increases is a $600,000 increase in job readiness training and personal development for non-custodial parents. However, about $680,000 is included for the same purpose in the allowance for the Family Investment Administration, level funded with prior years. DHS has reported that the funding in CSA is not a new contract, but rather a new fund source for the same services. The Department of Legislative Services, or DLS, recommends reducing DHS's fiscal 2027 appropriation by $679,639 to correct the double budgeting of non-custodial parent training contracts. The largest increase in the budget is for cooperative reimbursement agreements. Those are agreements with local agencies that assume child support functions. Those agencies receive a 66% match from the federal government, and those funds are centrally budgeted in CSA. As shown in Exhibit 3 on page 7, funding for those agreements has varied widely over the last several years. DHS should comment on the substantial variation in those expenditures across years and why fiscal 2025 actual spending was $23.5 million below spending in fiscal 2024. Beginning at the bottom of page 7 is a discussion on the Child Support Reinvestment Fund. It's a fund that holds federal incentive payments based on performance against 5 measures set by the Federal Office of Child Support Enforcement. On page 9, Exhibit 4 outlines revenue into this fund as reported by DHS and the governor's budget books. As you can see, reported revenue is not consistent across sources, with fiscal 2024 showing an especially notable difference. Additionally, the fiscal 2025 closing balance of the fund differs significantly by source, with the Comptroller's Office reporting a closing balance of less than $1 million, and DHS reporting that amount at over $15 million. DHS should comment on the discrepancies in the Child Support Reinvestment Fund revenue and balances reported between sources. On page 10, Exhibit 5 shows expenditures from the Child Support Reinvestment Fund. Unlike most other funds, DHS cannot use these funds to draw down the typical 66% federal fund participation. However, several of the proposed deficiency appropriations add both funds from this source as well as funds that appear as federal matching funds. DHS should comment on how the agency will address any potential shortfalls resulting from including federal matching funds in appropriations utilizing the Child Support Reinvestment Fund. Additionally, beginning in fiscal 2025, DHS has made appropriations from the Child Support Reinvestment Fund in areas that have not traditionally received funds from that source and do not have a readily available relationship to child support functions. DHS should comment on why child support reinvestment funds are being used for sources outside of CSA or local child support enforcement functions, as well as how these uses support child support service activities. DHS should also comment on the limited budgeting of funds from this source in fiscal 2026 and 2027, despite reporting a fiscal 25 closing balance exceeding $15 million and having additional revenue received since that time. On page 11 is the personnel section. As of December 31st, 2025, CSA had 49.5 vacant positions. The vast majority of those had been vacant less than a year. The key observations section begins on page 12 with a discussion of child support performance using the 5 federal incentive measures I discussed earlier. Exhibit 6 on page 13 shows statewide performance in 4 of those measures at federal fiscal year close compared to both the federal as well as the state goals. All measures declined compared to fiscal 2024, but all of them declined by less than 1 percentage point. Exhibit 7 on page 14 shows the 5th measure, cost effectiveness, including an estimate provided by DHS for fiscal 2025. Between fiscal 21 and 24, cost effectiveness fell each year, reaching $2.51 collected for every dollar spent in fiscal 2024. It's about half the federal goal. DHS estimates that cost effectiveness saw a substantial improvement in fiscal 2025 and reports that the actual cost effectiveness number will be available in April. On page 15, Exhibit 8 shows counties that did not meet the state goal for 4 of the federal incentive measures. That's also at federal fiscal year close. Overall, 5 jurisdictions met or exceeded all 4 goals measured, while 3 did not meet any of those goals. However, DHS reported that the jurisdiction data was only preliminary, and the final data was reported to the federal government at the end of December. DHS should comment on whether there were any changes between the preliminary data and final numbers for federal fiscal 2025. Additionally, DHS should comment on measures being taken to improve local performance in the federal incentive goals. On page 16, Exhibit 2 discusses the child support management system, which was implemented beginning back in 2022. A big topic in recent years has been the federal certification of the system, and DHS did provide an update on that in February in a JCR response. DHS reported that the certification process began in January, and they anticipate that final certification will be available in July. On page 17, Issue 3 discusses motor vehicle license suspensions, including changes made to the process by Chapter 578 of 2025. DHS should discuss any efforts to implement the changes in the driver's license suspension program. Additionally, in April 2025, the Office of Legislative Audits published an audit of CSA that contained one finding, which was that CSA did not have sufficient procedures to ensure that the Motor Vehicle Administration suspended the driver's licenses of non-custodial parents who were delinquent in their child support payments. CSA noted that they would implement a new report for local offices to locate and resolve potential data entry issues and provide training on how to use that report. DHS should comment on specific steps being taken to ensure that local offices are utilizing that report. On pages 19 through 21 are a list of DLS recommended actions. In addition to the first one that was already discussed, DLS recommends committee narrative requesting 3 reports on performance data against the 5 federal incentive measures. It's been a request over the last several years. Additionally, DLS recommends committee narrative requesting a reconciliation of the Child Support Reinvestment Fund, including revenue, expenditures, and balance information for fiscal 2019 through fiscal 2026. And finally, DLS recommends deleting the special fund deficiency for the Constituent Services Call Center as was discussed in the analysis for DHS administration, to more closely align with the agency's projected need based on contract costs. With that, I conclude my presentation, but I'm happy to answer any questions.
Thank you, and seeing no questions, if we can call up the agency, Madam Secretary Gloria Brown Barnett.
Good afternoon, Chair McCray and members of the subcommittee. I'm Gloria Brown Burnett, Interim Secretary of the Maryland Department of Human Services. I want to acknowledge my team, including Chief Financial Officer Roman Napoli, Jarnice Johnson, Executive Director of the Child Support Administration, and Aaron Easton, CSA's Chief of Staff. And thank you, Mr. Brown, for your thorough and thoughtful analysis. Members of our leadership team are also in the audience, including Courtney Thomas Winterberg, Director of the Allegheny County Department of Social Services. The mission of our Child Support Administration is to encourage responsible parenting, family self-sufficiency, and child well-being. We work with parents to provide the financial, medical, and emotional support their children need to grow and thrive. In federal fiscal year 2025, CSA collected and distributed $450 million in child support payments and served over 155,000 Maryland families. In 2025, we updated the driver's license suspension program, a legislative Black Caucus top priority, and changed the noncompliance timeline for referral to the Motor Vehicle Administration for suspension from 60 days to 120 days. These new legislative changes are exempted non-custodial parents whose income is at or below 250% of the federal poverty level. We made system changes to implement the changes to the definition of actual adjusted income to include a deduction for each child living in the parent's home for whom the parent owes a duty to support. Additionally, we hosted a statewide amnesty program which collected over $790,000 in previously unpaid child support and reinstated 2,383 driver's licenses. We celebrated the 50th anniversary of Title IV-D Child Support Program by hosting a series of events and resource fairs and highlighting our payment incentive program to help non-custodial parents reduce their arrears. Within DHS, we improved the interface between the child support management system and the eligibility enrollment system to better exchange data. This increased the data match rate across programs to 82%. In 2026, we are prioritizing increasing and enhancing partnerships with community-based partners to develop additional non-custodial parent employment training programs to help those who need job skills and create employment opportunities. Fostering a culture of performance improvement through clear communication of performance expectations and metrics to all employees, and continuing to develop the requirements to implement the new child support pass-through requirements to pass through 100% of the child support to current recipients receiving public assistance over a 4-year period. I now turn to Aaron, to begin our response to the DLS prompts.
Good afternoon, Mr. Chair and members of the subcommittee. For the record, my name is Aaron Easton, Chief of Staff of the Child Support Administration. The department was asked to respond to the comment on page 2 of the analysis regarding the deficiency for the vendor who performs child support services of our Baltimore City location, and why the portion of the shortfall that was related to the transaction fee from fiscal 2025 was not paid using fiscal 2025 appropriation. The fiscal 25 budget request was submitted using old contracts cost information because the budget was submitted prior to the new contract being awarded. The transition fee was paid with fiscal year 25. The department was asked to comment on the recommendation on page 5 to reduce DHS's fiscal 2027 appropriation by $679,639 to correct the double budgeting of non-custodial parent training contracts. We respectfully do not concur with this recommendation and the DLS assessment that this is a duplication of funding. Using Title IV-D funding, in addition to the funding budgeted in FIA, will allow for the expansion of the program to include a re-entry component for previously incarcerated non-custodial parents. The program will provide services such as job placement, legal aid for order modifications, and arrearage reduction. These programs often begin during incarceration to assist with financial planning, job readiness, and family reconciliation. If funding is lost, we would not be able to expand our program to include reentry services. The department was asked to comment on page 6 regarding the cooperative reimbursement agreements and the variation of expenditures across years and the reduction in 2025 spending as compared to 2024. While we are working to identify why reported CRA expenditures decreased in 2025 compared to 2024, we do believe that the expenditures shown in the chart for federal fiscal year 2024 are actually contract amounts and not actual spending. It appears the department encumbered the entire contract amount, contributing to the spike shown in that chart. Please note that some of these agreements run on a multi-year basis. The actual expenditures for all cooperative reimbursement agreements in federal fiscal year 2024 is $17.4 million. The expenditures for federal fiscal year 2025 stands as of today at $11.4 million, with additional $1 million in invoices in the review process. We would also like to note that we believe part of the disparity may be because our figures and analysis is calculated on a federal fiscal year and not a state fiscal year. The cooperative reimbursement agreements have terms that run on the federal fiscal year and not the state fiscal year. I now turn it over to Roman for the next responses.
Thank you. On the discrepancies in child support reinvestment funding revenue and balances, as reported on page 7, we do actually believe there is some miscommunication about how we're working around the word revenue, and there may be some differences in how that terminology was discussed during the review and questioning process. For instance, some of the ways we at DHS often talk about revenue as funds that are awarded to us by the federal government in any given year. And other times we refer to these funds as expenditures that match the revenue in terms of balancing your books as an accountant would. DHS needs to estimate how much will be awarded in each year, meaning the amount of funds received may change depending on the data when the data was reported. For example, the amount that Maryland receives is based on the second preceding year's performance. Yet, DHS plans its budget 1 year ahead when the governor's allowance is presented and the appropriation year begins. This causes a timing misalignment that impacts our ability to accurately provide revenues as we understand DLS was seeking. We plan to work with our colleagues in DLS to make sure that we understand exactly how we want to report this information and moving forward ensure that they have the balances before the session begins. On how DHS will address any potential shortfalls resulting from including federal matching funds and appropriations utilizing the Child Support Reinvestment Fund. Per federal statute, we do not use CSRF to match federal funds. We intend that for this 2020 deficiency to be 100% funded with the CSRF. For comment on page 11 on why child support reinvestment funds are being used for sources outside of CSA or LDSS child support enforcement functions and how we support those activities. The 2025 CSRF budget amendment for $4 million was mistakenly recorded under FIA local offices, GO02. We acknowledge that mistake, but they were used for allowable expenditures. When DHS entered 2025 expenditures into the system this year, we did not report a correct amount for these expenditures, and that is why it was incorrectly reported in FEMAS. DBM inputted a technical review adjustment to ensure the data budget book for 2025 more closely aligned and reflected the amount of funding that was actually spent, and which was informed by prior year expenditures. This adjustment incorrectly displayed the expenditures again in the GO02 CRS funds, which were not used to draw down federal matching funds. FEMA's entry showed that the CSRF funds were spent only in the two areas where the analysts would expect them to be, H008 and GO06 in 2025. The 2026 deficiency for foster care maintenance payments included $758,000 for CSRF to assist in funding a projected shortfall. The correct funding source for this budget item should have been the child support foster care offset. We used the wrong funding code. The FY 2027 CRS funding in the Office of the Secretary is for the DHS's call center contract, and that's why funding is reflected there. I'll now turn it over to Jarnis.
Good afternoon, Chairman McCray and members of the committee. On the changes between the preliminary data and final numbers reported to HHS noted on page 14 and measures being taken to improve the LDSS performance in the federal incentive goals. There were no changes in the performance data that was submitted to HHS. CSA has implemented mandatory training and is working to provide additional tools to our local leadership in an effort to work on performance consistently throughout the federal fiscal year. We are meeting with the local leadership quarterly to specifically review ways to improve performance and to identify any barriers that are seen locally to meeting performance goals. We also have developed a new orientation series to assist new directors and assistant directors in understanding the child support program. On efforts to implement the changes in the driver's license suspension program as outlined on page 17. In 5 months, just want to stress 5 months, we completely rebuilt and restructured the entire driver's license suspension program, as well as delivered statewide training and additional resources to local offices to implement 2025 legislation. Staff were trained not only in changes in the law, but the entire change of the process for the program. As a result, to date, there have been 0 licenses suspended by DHS since the new law was implemented in October. On the specific steps taken to ensure that the local Department of Social Services are utilizing the no-match report to address rejected referrals, as noted on page 18. CSA has conducted mandatory training and submitted a quarterly review of the report to ensure that the local offices are working on the report and recording efforts to update the data where possible. These referrals were made prior to the change in the new law and the driver's license suspension implementation in October. Since that time, we have not been able to select individuals for the driver's license suspension program, resulting in no rejected referrals since October 1 of 2025. On the recommendation to reduce federal funding for the non-custodial parent employment and training contracts, as noted in our response to number 2 above, we respectfully do not concur with the reduction of the DLS assessment that this is a duplication of a request for funding. The intent of this request is to expand the level of services provided to our customers. Utilizing 4D funding will allow for the expansion of the program to include a reentry component for previously incarcerated non-custodial parents. Child support reentry programs help formerly incarcerated individuals manage or modify child support obligations, which prevents debt accumulation and supports successful reintegration. We concur with the recommendation for number 2 regarding the child support performance reports. We also concur with the recommendation for a report on the reconciliation of the child support funds. On the recommendation to add language regarding N00H0008, child support, state child support administration, we respectfully do not concur. As discussed at earlier budget hearings, the funding split for the Constituent Services Call Center contract must maintain a balance of general, special, and federal funds aligned to the grants and sources that fund it. The special fund authority to fund the contract and operations must be maintained. DHS and the Department of Budget and Management undertook a multi-step process to more accurately reflect the cost centers for call center contracts in 2026 and 2027. As a result, total call center spending across the agency decreased through realigning funds to the correct cost centers, meant some programs and fund types saw funding increases while others saw decreases.
We're happy to take questions.
Seeing no questions, Madam Secretary, if you guys could just, we got one person that's giving public testimony. Ms. Moore.
You want me to stay up here or?
No, ma'am.
Good afternoon, Chair. Good afternoon, Vice Chair and Committee. My name is Sharmika Moore, and I'm a member of the Ask Me Local 112. I'm a child support specialist for 5 years and currently serving as a lead worker in Baltimore County. Right now, individual caseloads in our office range over 900 with a max of 1,500 per caseworker. That number alone should give pause. These are not files, these are families. These are children relying on us to ensure court-ordered support is enforced and distributed accurately and timely. At the same time, we are navigating structural obstacles to make our work harder, not easier. The centralized call center was designed to reduce the burden on local office. Instead, it has created more work. Call center representatives are unable to complete basic updates such as correcting phone numbers or addresses. Customers are frequently given incorrect information and sent directly to our office, frustrated and confused. That misinformation leads to escalations, complaints, and hours of additional corrective work for already overwhelmed staff. The workload continues to increase due to systematic errors that are reported daily on a case-by-case basis. It has caused an influx in requests for investigations which require child support specialists to complete the task of CPA. Which the complexity of our cases continue to grow, compensation does not reflect that reality. Several of my coworkers maintain second jobs just to stay afloat. We are trained professionals handling sensitive financial legal matters for families across Baltimore County. They should not have to clock out of one job to clock into another one just to pay rent or childcare. High caseloads leads to burnouts, burnouts leads to turnovers, and turnovers harm the very families that we serve. We are asking for meaningful raises and budget investments that address staffing retention. Supporting state employees is not a luxury. It is essentially to maintain effective services for Maryland children and families. I thank you all for your time.
First, just want to say thank you for your advocacy, and I too believe that people should be able to work one job as an electrician that come out of a labor union. So I heard you very loud and clear. I wanted to lean back in and say to the agency, well, we'll get to see you again. We'll see you for the next one too. So I'll save that for the last. But I do see a number of my friends would ask me, and just want to say that it's great to see you back there. And Connor, this will be our last time seeing you. So Mr. Brown, I just want to say thank you for just helping us see the board a little bit more clear, navigating a number of the different agencies that we've had before us. Colleagues, this will bring us to our last agency hearing. DHS Office of Home Energy Program, and it will be Mrs. Saveksha Bujel.
Thank you, Mr. Chair. The operating budget for the Office of Home Energy Program decreases by 0.7 million or 0.3% to a total of 300.9 million in fiscal 27. We will start with the MFR data. Exhibit 1 on page 4 shows vulnerable populations receiving energy assistance benefits. The percentage of households with a member over age 60 and households with an individual with a disability receiving benefits increased in fiscal 2025. However, the percentage of households with a child under age 6 decreased. We are asking DHS to comment on the reason for this decrease and its efforts to increase participation. Previously, DHS had included in its annual MFR submission a measure of participation rate in the benefit programs, overall comparing the numbers participated to the estimated eligible. The fiscal 27 submission did not include general participation rate measures. DLS recommends adopting committee narrative requesting data on vulnerable populations and general participation rate measures for energy assistance benefits. As shown in Exhibit 2 on page 6, in federal fiscal 2024, the average annual energy burden after receiving low-income home energy program benefits was lower for both all households and high-energy burden households compared to federal fiscal 2023. As shown in Exhibit 3 on page 7, the Benefit Targeting Index, which focuses on the extent to which highest benefits are paid to those with highest energy burden, has decreased each year since fiscal 2020. The Benefit Targeting Index of 98 in federal fiscal 2024 indicates that households with the highest energy burden saw a 2% lower benefit compared to all households. Due to the federal government shutdown, LIHEAP allocation for federal fiscal 2026 was delayed. As a result, under the state of emergency that was declared in Maryland in October 2025, the use of Strategic Energy Investment Fund was authorized to support Maryland Energy Assistance Program for the month of November. A budget amendment appropriated $10.1 million from SEIF to cover the projected need of MEEP in November. The fiscal 27 budget contains deficiency appropriation totaling $3.9 million, $2.4 million is in special funds and $1.5 million in federal funds. The proposed deficiency appropriation includes realignment of $22.5 million from the LIHEAP grant for MEEP benefits that was labeled as call center in error in fiscal 26 budget, $2.1 million for local administering agencies to fund contracts to process energy assistance applications, $1.5 million from the LIHEAP grant for MEEP benefits, $1 million for LAAs associated with fund realignments, a reduction of about $0.7 million associated with electric benefits and outreach expenditures. Exhibit 4 on page 9 is the overview of agency spending. $280.8 million or 94% of the OHIP budget supports energy assistance benefits. Funding for Electric Universal Service Program benefits, or USP, including both electric bill payments and arrearage assistance, totals $197.8 million or 66% of the budget. The funding level for the USP program varies primarily with the availability of SEIF revenues allocated by statute for energy assistance. Funding for MEEP energy assistance benefit account for $82.6 million of the budget. Exhibit 5 on page 10 is the proposed budget change chart. Fiscal 27 allowance for OHIP decreases by $0.7 million or 0.3% compared to fiscal 26 after accounting for proposed deficiency appropriations. This decrease is primarily associated with a decrease of $1 million associated with local administrating agencies and a decrease of $0.4 million associated with personnel expenses. Total federal LIHEAP funding included in fiscal 27 allowance, including both funding for energy assistance and program administrative costs, total $94.7 million, of which $82.6 million are budgeted for energy assistance. Additionally, in federal fiscal 26, total LIHEAP funding for all states increased by $20 million. DHS reports that although it has not received notice of award, it expects supplemental funds to be provided due to the increased funding. The annual amount of USP ratepayer surcharge revenue collection is set as $37 million to provide bill assistance, low-income residential weatherization, and retirement of arrearages. OHIP administers the bill assistance and arrearage retirement components of USP, including funding for both energy assistance benefits and program administration. $50.2 million is budgeted in fiscal 27 allowance, which is about $13.2 million more than the annual maximum collection amount. Including the deficiency appropriation of $9.8 million, USP ratepayer surcharge revenue total $58.7 million in fiscal 26. Although deficiency appropriation increased the amount of funds over the limit in fiscal 26, the budgeted amount exceeded the maximum collection amount by 11.9 million. DHS reports that the funds in excess of maximum collection amount were an error and they will ensure that USP funds are not overspent. DHS reports that the funds in excess of the 37 million will be provided through SEEF and funds available from the Public Service Commission order related to an electric generating facility at Dominion Cove Point. In the analysis for DHS administration, DLS has recommended reducing funds for constituent services call center, 3.4 million in USP funds included in fiscal 27 allowance and 7.5 million provided through a fiscal 26 deficiency appropriation. If accepted, these recommendations would reduce the amount of USP revenue budgeted over the maximum amount. However, USP would still be over the maximum collection amount in both fiscal years. As shown in Exhibit 6 on page 11, USP use for administrative purposes has increased in recent years. Particularly in fiscal 26 and 27, the amount of USP revenues set aside for DHS administration and OHIP expenditures that are not associated with assistance increased significantly. We are asking DHS to discuss its efforts to ensure correct funds are used to cover the expenditures and how funds for DCP are available to replace the USP revenues, since fiscal 27 allowance already budgets the annual contribution of $400,000 for energy assistance. DHS should also discuss the growth in administrative spending from these funds in recent years. Next discussion covers the Strategic Energy Investment Fund. As shown in Exhibit 7 on page 14, revenues have grown substantially in recent years due to increase in regional greenhouse gas initiative auction clearing prices. Total RGGI program revenues received by Maryland from all auctions held in fiscal 25 total $267.5 million, which is the highest yearly revenue in program history. Exhibit 8 on page 16 provides a historical summary of the annual levels of SEEF funds budgeted for energy assistance through OHIP. Fiscal 27 allowance includes $160 million in SEEF funds. As shown in Exhibit 9 on page 17, the anticipated closing balance of the energy assistance sub-account of SEEF is $52.8 million in fiscal 27. If DHS uses SEEF to cover all expenditures budgeted from USP ratepayer surcharge revenue and error in both fiscal 26 and 27, the anticipated closing balance will be $31.7 million in fiscal 26 and $18.5 million in fiscal 27. DLS notes that the funds in the energy assistance sub-account of SEEF are only authorized to support energy assistance. DHS should comment on how much of the expenditures that were budgeted from USP ratepayer surcharge revenue will be covered by SEEF, given that some of the USP overages are associated with administrative expenses. DHS should discuss how it intends to cover these expenses. On page 18, we have the personnel data. The number of positions in OHIP decreased by 2 in fiscal 27, of which 1 position is internally transferred within DHS and 1 position is closed. However, the total number of overall positions in DHS remain unchanged in fiscal 27. Given that a position is closed in OHIP and the total positions in DHS remain unchanged, DHS should comment on if or where there is a new authorized position in fiscal 27. Starting on page 19 is the issues section. The first issue covers energy assistance applications in fiscal 2025. As shown in Exhibit 10, total applications for energy assistance benefits have fluctuated in recent years. In fiscal 25, the number of applications for energy assistance decreased by 31.2% compared to fiscal 24. DHS reports that this decrease is associated with improvements in data reporting. In fiscal 25, DHS updated its system to detect and remove duplicate and incomplete applications. Although the number of applications received in fiscal 25 declined, the number of households receiving benefits increased. Between fiscal 2020 and 2025, the number of households receiving energy assistance benefits increased among all benefit types. And the increase in household receiving MEP and gas arrearage assistance in fiscal 2025 is primarily due to OHIP pausing issuance of benefits in fiscal 24. In April 2024, funding for certain benefit types were exhausted and DHS stopped issuing new benefits, decreasing the recipients of these programs. In fiscal 2025, the benefit amount were reduced for the bill payment programs to accommodate the anticipated increase in number of eligible households. However, even with the increased number of recipients, benefit expenditures were lower than expected. As a result, OHIP issued supplemental benefits at the end of the year for USP bill assistance and MEP. Exhibit 11 on page 21 shows the supplemental benefits for both of these programs, which ranged from $150 to $400. As shown in Exhibit 12 on page 22, not accounting for the supplemental benefit, the average MEP payment in fiscal 25 was $174, and average USP payment was $258. And the average supplemental benefit provided for MEP was $272, and for USP was $291. Exhibit 13 on page 23 shows the average benefit size for both bill payment assistance program in fiscal 2025. The average benefit size decreased compared to fiscal 2024. Each year, OHIP examines expected number of applications and recipients and adjust benefit levels based on estimated available funding. As the estimated number of eligible households decreased, OHIP increased the benefit amount in fiscal 26 for the bill payment programs. However, the increased benefit level is lower than the benefits that was provided in fiscal 25 after accounting for supplemental benefits. Average benefits in fiscal 26 remain substantially below benefit levels in prior years. Exhibit 14 on page 24 shows energy assistance applications and benefit data. Through December 2025, fiscal 26 applications for our all energy assistance, except for the crisis benefit program, have increased compared to applications during the same period in fiscal 25. The increase indicates continued high demand for energy assistance as energy prices have continued to increase through the first half of the fiscal year. DHS should comment on if it has seen additional recent growth in applications. Consistent with the higher number of applications, the number of households receiving energy assistance benefits has also increased for all programs except for USP Arrearage Assistance Program. Households are eligible to receive arrearage assistance once every 5 years. Limitations on eligibility for this program result in higher rates of denials, as well as fluctuations in number of households receiving the benefit. Total benefits paid in fiscal 26 through December have increased by $33.9 million or 68.4% compared to benefits paid during the same period in fiscal 25. This increase is primarily due to the benefits paid through December 2024 not accounting for supplemental benefits that was provided later in the fiscal year. Language in fiscal 26 budget bill restricted funds pending submission of a report on application denial rates. DHS has submitted the report and issues 2 and 3 cover information provided. As shown in Exhibit 15 on page 26, application denial rates in fiscal 24 for all benefit types were highest since at least fiscal 2014. DHS notes that the substantial increase in denial rates in fiscal 24 is associated with implementation of categorical eligibility. Denial rates have decreased for all benefit types during fiscal 26 as of November 1, 2025 compared to fiscal 25. Exhibit 16 on page 28 shows the most common reasons for application denial. The third issue covers energy assistance application processing times, as shown in Exhibit 17 on page 29. In fiscal 2026, the statewide average number of days to process an application was 25 days. Increases in the average number of days to process applications since fiscal 25 have occurred in 7 LAAs. Exhibit 18 on page 31 shows application process beyond the 55-day guideline. In fiscal 26, 7.9% of applications statewide have been processed in longer than 55 days. DHS should comment on the reasons for high percentages of applications processed beyond the 55 days. DLS determines the information provided complies with language restricting the special funds and therefore recommends the release of $250,000 in withheld funds. DLS will process later in this effect if no objections are raised by committees during the budget hearings. DLS recommends restricting funds pending submission of a report on energy assistance application processing times and denial rates. Starting on page 33 is the recommended actions. The first recommendation is to reduce general funds for personnel expenses. Administrative costs for OHIP are supported with special and federal funds. Second recommendation is a language withholding funds until a report is submitted providing fiscal 26 and 27 year-to-date application processing times and denial rates. The third recommendation is a committee narrative requesting fiscal 26 MFR data. That concludes my presentation, and I'll take any questions you may have.
Thank you, Ms. Pujol. And seeing no questions, Madam Secretary, before you get started, if you can limit it to responses, and it looks like you concur with a number of it, so please speak to the stuff you disagree with.
Thank you. I just want to introduce the people here at the table with me today. Rigel Moore is our new lead for our Office of Home Energy Programs, and Roman Napoli is our Chief Financial Officer. And I will
take it from there. Thank you, sir. On page 4, we were asked to comment on reasons for the decrease in participation among households with children under 6. In 2025, we updated our managing for results methodology to refine the reporting logic. In parallel, we updated historical data for 2024, but not prior years, due to reporting challenges with our data system. As a result, 23 and 25 figures are not directly comparable. We believe there's not been an actual decrease in participation. We concur with the DLS recommendation on page 5. We were asked to comment on page 12 on how to ensure that funds are used to cover the expenditures under the EUSP revenues. So DHS submits an annual EUSP operational plan to the Public Service Commission, which outlines the planned use of these funds and to administer electronic payment and arrearage benefits. The Commission approved the plan based on available statutory funding for EUSP ratepayers at $37,400,000 for the DCP and 26 CEF appropriations of $150 million. The governor's allowance reduces the EUSP ratepayer allocation in the FY 2027 by $700,000. The additional FY 2027 $12.7 million, as earlier noted, was an error. The FY 2026 local administrating agencies received a 5% increase in funding for program operations, the first increase in 4 years. This program operations funding has been realigned in the governor's allowance, and it also covers the cost share, previously 40% state funds and 60 federal, to a transition to a 50-50 split in 2025. The realignment was driven by a number of households served by each program and funding availability. On the DLS request on page 16 to discuss expenditures, an additional $500,000 was budgeted for EUSP in error, an additional $200,000 was subtracted for outreach funding. The total is $700,000 will be charged to the 27 CEF allocation. On the DLS request on page 18 regarding staffing levels within OHEP, as we have discussed in our other budget hearings, the reduction of PINs is due to cleanup across our data. The specific PIN was previously frozen, and we are now actively recruiting for this position and hope to fill it in the first half of 2026. With that, I turn it over to Rigel.
Thank you. On whether OHEP has seen additional recent growth in applications, the answer to that is yes. Applications has remained relatively consistent with trends cited in the DLS analysts. Through January 31st, 2026, unduplicated applications have increased by 23.37% comparing to FY25 to FY26 year to date. On the question On the reasons for processing applications beyond 55 days in Caroline County, Montgomery County, and Southern Maryland and Howard, we continue to closely monitor processing timelines, and performance has improved significantly over the past 3 fiscal years. Overall, the percentage of applications processed beyond 55 days has decreased from 29% in FY24 to 12.5% in FY25, and further to 7.9% in last November. With respect to 4 named areas or organizations, with Caroline County, we helped restructure internal workflows, eliminating outdated practices, and implementing strengthened case tracking and queue management protocols. Montgomery County has seen a 25% year-to-date increase in applications between FY25 and FY26, while simultaneously reducing their application backlog by 11.9%. We continue to work with county staff to improve their inter-office operations. Southern Maryland has faced staffing and leadership challenges this fiscal year due to employees being on extended leave. As of November 1st, 2025, 24.5% of applications exceeded 55 days. We're going to continue to work with Southern Maryland on a biweekly basis. Howard County has made notable progress through targeted staff training and process modernization efforts, reducing application processing over 55 days by 16.6 percentage points compared to FY25. We concur with DLS recommendation to release $250,000 in withheld special funds noted on page 32. We also concur with DLS recommendation on page 32 to restrict funds pending submission of a report on energy assistance application processing times and denial rates. For responses to DLS operating recommendation actions beginning on page 33 of the DLS analysis, we concur with the reduction of $46,229 for personnel expenses. We concur with the request of OHEP application data, but we ask for a submission at a later date, January 31st, in order for us to further analyze and validate our data. Lastly, we concur with the managing for results requests for participation rates for FY26.
And we are ready to take your questions.
Senator Augustine.
Just for my clarification, the contractual services, the 300 million that it shows on here, on the appendix 2, it says contractual services. It's like 300.
Okay, yes.
What is it?
That's for the agreements for our vendors, our local contractors to pay for. They administer OHEP program within their local agencies.
$300 million? I'm just asking. You all could go, we don't need to hold up time. You don't need to do it now. Okay. If you could, just share with me just like what that is, I'd be grateful.
Okay, we'll circle back with you. Thank you.
Thank you.
Seeing no further questions, Madam Secretary, it's been a pleasure to have you. I know it's a tough agency. And Malcolm Augustine, Senator Augustine, was singing high praises, and you have delivered. I said you delivered. But colleagues and Ms. Bujel, just want to say thank you again, as all of the other analysts, just helping us to be able to see the board more clear. Colleagues, this is our last hearing. It's our last hearing. It is our last agency, and I cannot tell you I would not rather work with a better group than you all. Thank you again.